So hi, my name is Nicole Tartaglia, and I'm happy to be here today to speak about the Extraordinary Baby Study, which is a study of infants prenatally diagnosed with sex chromosome trisomy. I plan today to go through the background of sex chromosome trisomies briefly and talk about the Extraordinary Baby Study design and methods, give some updates in terms of progress to date. We're now 4 years into the study, and so we have some updates related to progress and recruitment and all of those things. I want to share some of our early results and then talk a little bit about the consideration of these conditions in terms of newborn screening. So first of all, just again, to start with some background on sex chromosome aneuploidy, it occurs in 1 in 400 live births. It occurs in males and females at different rates and with different combinations of X and Y chromosomes. The most common sex chromosome aneuploidy conditions are the trisomies, which include Klinefelter syndrome, XXY, which is about 1 in 6 female births, 47XYY, also sometimes called Jacob syndrome, and then trisomy X in females. There's many other tetrasomy and pentasomy conditions that become more rare as there's more X and Y chromosomes, and also that include more and more neurodevelopmental and medical involvement. And then also, obviously, in females, we have Turner syndrome, which is another, very important cohort to study, but is not included in our current study because there is so much other research that's already out there on Turner syndrome, and so we did not include it in the current study. So first, just thinking about some of the physical features, there's really minimal facial dysmorphic features in the sex chromosome aneuploidy conditions. Sometimes you'll hear about epicanthal folds or hypertelorism on the extremities. Sometimes you'll hear about clinodactyly or flat feet, but these are definitely subtle and not universal, and there's not a striking facies that people recognize to be associated with sex chromosome aneuploidy conditions. The most characteristic physical features occur in Klinefelter syndrome. I think all of us remember from training the picture of Klinefelter syndrome with the guy in black and white standing next to the pole with his bar over his eyes. This was the classic phenotype that was described, but is definitely not the way all individuals with Klinefelter syndrome present, and I would say is still in the minority of the way that individuals with Klinefelter syndrome present. But there are features that are common that include tall stature, narrow shoulders, increased risk for gynecomastia, which we'll talk about a little bit later as well, but is actually much less common than originally described in the pediatric population and if testosterone is started on time. Small testes are universal in non-mosaic males with Klinefelter syndrome, and then infertility is also a characteristic feature. Although this is also changing drastically as advanced reproductive technologies have allowed sperm retrieval for in vitro fertilization purposes in up to 50% of adult males with Klinefelter syndrome. So there's a lot changing in terms of the fertility world in these conditions as well. So one thing that is important to talk about is testicular function in XXY, and really this is the same for any condition where there's an extra X chromosome in males. So XXYY, triple XY, and any other condition where there's extra X's in males. So what happens typically is shown here in the slides with the dotted line. So in a typical XY male, what you can see is in the infancy period, in the first few months of life, there's what's called a mini puberty of infancy and a peak in testosterone production that then is finished after the first few months of life, and then there is very minimal testosterone and no testosterone production through childhood until puberty, when the testes are kind of activated again and the Leydig cells start to produce testosterone, and there's a surge in testosterone that is then reaches an adult level by the end of puberty, and that is maintained at adult levels until the very late adulthood when they start to decline again slightly. In XXY, we have evidence to support that there is indeed a mini puberty of infancy in many individuals at least, but it can be blunted. And so there's, a lot of research and questions about testosterone during this time period related to treatment in XXY. It is similarly very low through childhood, and then puberty typically starts around the normal time in XXY, and testosterone will increase, but it does not reach the typical adult levels, and then through endocrinologic care, testosterone replacement therapy is started at some point during puberty for those, the majority of those who do need testosterone replacement, and then maintain throughout adulthood up to with the goal of achieving typical male level. We do know that there is a higher rate of micropenis and poor penile growth in some infants with XXY. There are some features of hypotonia as well. And like I said, you know, plus or minus lower testosterone levels, but on average, what we've been finding is that the levels in males with XXY, which are plotted here compared to typical males in infancy, tend to be lower. In the all the conditions with extra X and Y chromosomes, so this includes trisomy X and XYY as well, there are higher rates of many other medical conditions as well. I'm not going to go through all of these, but it is important to know that there are many systems involved, and there can be higher rates of things like seizures and allergies and atopy, and definitely adult conditions such as metabolic syndrome or type 2 diabetes. And in females with trisomy X, higher rates of premature ovarian failure. So these are all things that also become important in the medical care and follow-up of individuals with X and Y chromosome aneuploidies. Talking about the neurodevelopmental features, this is a representation of mean IQ scores from the prospective studies that were done in the 70s, 80s, and early 90s by many researchers nationwide and actually across the world, looking at different cohorts of individuals who were identified at birth. What these researchers found following these patients prospectively through young adulthood was that cognitive features there was definitely cognitive involvement, but it was not as drastic or significant as the original reports of the sex chromosome aneuploidies, or as many of the other known genetic disorders such as trisomy 21, where mean cognitive scores are much lower. So here you can see a typical IQ score, bell curve with a mean of 100 in the control group. And when you look at XYY, the curve is just slightly shifted down with mean IQs in the 90s, the same for XXY, and then trisomy X slightly lower. And so overall, you can see there's a lot of overlap with the general population, but there is a tail of individuals who tend to have slightly lower cognitive abilities with some challenges from those. If you look at early neurodevelopment in these conditions, there's a higher rate of developmental delays. There's, in terms of speech and motor delays, delayed babbling, delayed first words and two-word phrases, and expressive delays have been described to be more significant compared to receptive delays. In the prospective studies, approximately 75% required speech therapy in the birth to 3 period. And motor skills similarly were slightly delayed. Average age of first steps is 14 to 15 months, which is not drastically different than the typical population, which is between 12 to 13 months, but on average was slightly later. And then in terms of other motor findings, low muscle tone, decreased coordination and motor planning, and in the prospective studies, 50% required motor therapy. Some of the more important conditions that are associated with the X and Y variations include the features that can occur and present at school age and beyond, and that also are not necessarily always correlated with cognitive abilities. You can have cognitive abilities and IQ scores that are in the typical range, but still have learning disabilities that cause significant challenges. And so in the prospective studies, 75% actually met criteria for reading disability and dyslexia, and 75% required special education support in school. And this is pretty significant and also consistent with what we tend to see in clinical samples, at least in various populations in our clinics. This is a list of all the other risks that can come along with the sex chromosome aneuploidy conditions in terms of neurodevelopmental diagnoses. And you can see here, there's a long list of many things. the dyslexia that we spoke about, definitely speech and language disorders, motor skills disorders, executive functioning, and ADHD, which is present in a large cohort of these conditions, social difficulties, including increased risk for autism spectrum disorders, and then increased risk for various emotional and psychological features such as anxiety or depression. Again, there is pretty significant phenotypic variability and increased risk for many things. You know, there's definitely many individuals with the X and Y chromosome variations who also do not have a lot of challenges and aren't affected by these challenges. Historically, XXY and all of the sex chromosome aneuploidies have been under ascertained. Compared to what we know from genetic testing on birth cohorts, and then looking at the number of cases that are actually ascertained through medical testing, it's estimated that only approximately 30% of males with XXY were diagnosed in their lifetime. And so, and this I have to qualify as before an IPS, which we will talk about a little bit, but non-invasive prenatal testing, or the ability to test DNA in maternal blood and screen for genetic disorders that include the sex chromosome aneuploidies, has really changed this landscape, and there's definitely increasing ascertainment in the prenatal period of the sex chromosome aneuploidies. So prior to NIPS, this was kind of the idea that, you know, there was a chunk of children diagnosed in the prenatal period just based on previous genetic testing and screening recommendations, that there was a small percent diagnosed in childhood due to developmental delays, another small percent identified in adolescence related to testosterone deficiency, and then in adulthood, about 17% or, you know, around 20% were diagnosed due to fertility. And so this is the idea of, you know, again, a significant amount of those who would go through the lifetime without diagnosis. When we think about the theoretical effects of increased NIPS, and then also just what we actually are seeing in practice, is that this little fraction of prenatal diagnoses, here for XXY and then here for the trisomy X and XYY, has increased drastically because there are many more women being tested prenatally, and because the X and Y chromosomes are part of obviously what you would use for sex determination in terms of the NIPS testing, which is a motivation for many women and families to do the testing, there ends up being increased rates of diagnosis. So we now see a large percentage, and I think, you know, what percentage this is still really needs to be worked out, but this fraction is increasing. Increased number of patients with the prenatal diagnosis then also leads to many opportunities. It leads to opportunities for prospective natural history studies, which we'll talk about our study called the eXtraordinarY Baby Study. It is a nice cohort that actually is an enriched sample for increased risk for language disorders, for dyslexia, for autism, for anxiety. So a cohort that can teach us a lot about you know, some of these disorders that are more likely to develop in this sample. We have opportunities now also to do some better intervention studies and obviously genetic studies, and really improve care for this, this group of children and individuals. So whenever there is a prenatal diagnosis, of course, you know, some of the questions are, well, we talk very much about all the phenotypic variability, and the questions are always, so, you know, what's going to happen to my babies, or what are those predictors of positive outcomes versus negative outcomes? And this is a challenge for a lot of genetic counselors because there is not a lot of information out there. And I think, Alan, it's very challenging, and sometimes more challenging, to counsel about a set of conditions that have such wide variability, right? Because you can talk about what the risks are, but you really can't speak much more beyond that in terms of introducing all of the possibilities that could happen. And so this leads to a lot of challenges in terms of making decisions related to continuation of pregnancies after a diagnosis, and also just challenges in terms of what to expect and how to prepare in these conditions. So the goal of the eXtraordinarY Baby Study is to take advantage of the increasing prenatal diagnosis rate and this NIPS sampling to be able to really start to answer these questions and advance care and hopefully have a better understanding of the phenotypic variability and the predictors of outcomes in kids with sex chromosome trisomies. So this is a really big big graph or big schema of what our study is doing. And I know I'm going to walk through it a little bit, but obviously not go through every single detail. But the idea is that with the sex chromosome trisomies, there are definitely potential risk or protective factors that are present. And we really want to study and evaluate some of these early predictors in a cohort that is identified from birth. And so, you know, some of the things that we are looking at and that definitely have been shown to be protective or risk factors in other populations related to things like early intervention, access to care, community supports, parental education, and SES, and race and ethnicity. Some of the other medical features such as mosaicism, prematurity, birth weight, congenital anomalies, other family history and background genetics, and exposures as well. And so, we are really interested in thinking about how these predictors all together can impact outcomes. Clearly, there's other factors that are more specific to the sex chromosome aneuploidies that are important to study as well, such as gonadal function, including all of the lab abnormalities that can occur or that should be examined related to hormones, and then looking at some of the profiles of cognitive functioning and body composition and other things. And what we're doing is we're really, you know, collecting a lot of data points on all of these things over the course of early childhood, well, infancy to early childhood in the Extraordinary Baby Study to look at some of the outcomes from that you can measure in the first few years of life in terms of neurodevelopmental and cognitive and cardiometabolic outcomes. So, you know, given a 5-year grant period, our first outcomes have to be in early childhood, and we set 3 years of age as our primary endpoint. And so the idea is to take all of these outcomes at 3 years of age and then look back at what some of those predictors of the outcome variability is. The hope is that this cohort can continue to be followed through school age into adolescence and adulthood, when many of these other outcomes that we know can happen in the sex chromosome aneuploidies are able to be identified and measured, and that we'll really have a nice prospective data set that can help answer many questions related to development and related to physical health and hormonal function. So the aims of the study, like I talked about, were to describe the profiles of the neurodevelopmental, medical, and hormonal features during the first 3 to 4 years of life, specifically focusing on the trisomies, to identify risk factors and early predictors for poor neurodevelopmental and health outcomes. We're also looking at some tools that primary care doctors use to screen for neurodevelopment in these infants to determine what's the best set of tools when there is a prenatal diagnosis, to give guidance to pediatric practitioners. And we're also building a biobank along the way of DNA, RNA, and other samples for future studies, and have even done a little bit of preliminary work that has led to a supplement looking at metabolomics and some other things related to nutrition and dietary supplements in this population. So I think this biobank is also going to be a really rich source of further studies in the future. So the inclusion criteria of the study include that there has to be a prenatal diagnosis of a trisomy and then postnatal confirmation. So as many know, an IPS is not a diagnostic test, and there is varying positive predictive values and negative predictive values depending on the test and the timing of pregnancy and many other factors. So we do require that there is postnatal confirmation as well, or confirmation at least by amniocentesis. They have to enroll at 12 months or younger, and this is because we really want an unbiased sample. As much as we can have an unbiased sample, recognizing there's always some biases in our sampling. But what we didn't want was families joining the study because after 12 months, they started to become more concerned about delays, and then they wanted to be in the study. We chose a gestational age of 36 weeks, so we didn't have complications and confounders of prematurity, and also excluded anyone with other major medical problems that could confound results. We, still included many individuals who had some other minor conditions, but, obviously a big intraventricular hemorrhage or something else like that would confound our natural history study of just the effect of the trisomy. There's 2 sites. One is at University of Colorado in Denver. The other site is led by Dr. Judy Ross at Thomas Jefferson or Nemours in Delaware. And we conduct study visits at 2 months, 6 months, 12 months of age, some at 18 months of age if they're local families who can come without a lot of travel. And then again, after that yearly until, we are finished with the funding cycle. So with the goal and the key endpoint of getting as many patients as possible to this 3-year mark. It's been a little bit more challenging this past year with COVID, but I'll talk a little bit about the effects of our study on that. If they enroll at 6 months, they just start at this time point. So they just have to be enrolled at least by the 12-month visit. So some patients only have data starting at 12 months, and then many patients have data starting at 2 months or beyond. So, we have a big battery of assessments that are done while families come. And we talked about many of these before. And so, we get a lot of history. We do direct developmental assessments in a lot of different ways. We primarily use the Bayley scales of infant development and the Peabody scales for cognitive, motor, and language development. As they get older, we add in some other measures of those as well. We look at social development as well, using the ADOS and other measures of social development, including some eye tracking measures, adaptive functioning using the Vineland. This is a little baby in the P-pod, which is a sound plethysmography mechanism that can measure the difference between muscle and fat in terms of body composition. And so those little babies go in the P-pod, and then we're getting lots of labs and building our biobank as well. We are still enrolling trisomy X and XYY participants. And so if anyone knows of any prenatal diagnoses and wants to send them our way, we are still enrolling those because those cohorts are a little bit smaller. Before I go into talking a little bit more about the study, I wanted to spend a little bit of time talking about the support from NBSTRN in terms of how NBSTRN has played a role in this study. We were connected with NBSTRN initially, honestly, from the RFA that the grant was responding to, and reached out to find out about the resources that could be provided and support this project. And so the LPDR, the Longitudinal Pediatric Data Repository, was the component that was most relevant to our project, and really helped us in terms of providing common data elements and REDCap database building support, which is really important from the perspective of having a data set that obviously can be utilized well with some of the complications of a longitudinal data set, and then also having common data elements to facilitate data sharing with other conditions, especially other conditions within the newborn screening network, but other conditions as well with the rest of data sets nationally. So, the other important considerations related to doing the study with NBSTRN has been really thinking about the website and the strength of the website and data sharing mechanisms, dissemination of information and results about the study to our patients, but obviously also to the broader genetic and family communities, increasing public awareness, and all of these elements really make the study more meaningful to the families who are participating in it, to see the contributions that they're making. And I think really will be helpful for retention, especially hopefully in the continuation of the study, hoping that it's refunded over time to retain over the lifespan, right? So this is going to be a big commitment and for many of the families. And I think a lot of these things in terms of really showing the families how important it is important and will be helpful. And then personally, it's been really important for me professionally as well, because as a developmental pediatrician and not a geneticist, I was very familiar with ACMG, but not as familiar as I should have been. And so I've become a lot more involved and knowledgeable about the ACMG other programs as well, become a member of the steering committee and given a lot of opportunities to network with other researchers who are doing similar work or at least have can answer and talk about and build some other collaborations as well. So I think it's just been a really positive collaboration between with the NBSTRN and appreciate their support along the way for this study. Okay, so now to move on and tell you a little bit about enrollment and progress to date. As of May 2021, we have a total of 228 infants enrolled. This is the majority of the individuals are prenatal diagnoses of XXY. We also have 23 with XYY, 40 with trisomy X, and then 6 with XYY, which I'll tell you about in a little bit. Our goal for the XXY group was to only have 100, and we exceeded this goal. And we felt like, well, let's keep recruiting until we get at least to our goal of 200 individuals at the beginning, because we wanted to make sure we were building these cohorts the best that we could. We've had less enrollment, although we're getting there for our XYY and trisomy X populations, and are still recruiting new babies to these cohorts because we really feel the N has to increase for a lot of our statistical analyses to be valid. And so we're just hoping that even though we are coming to the end of the grant period, we will be able to continue to follow them. There were many, actually 6 individuals where prenatal testing showed XYY or XXY, but postnatal confirmation was actually 48 XXYY. So these were infants that we have also continued to follow, although it's a small cohort in a rare condition, but a unique opportunity to follow this group as well. And so overall, again, 228. This, with all the study visits, has been over 625 total study visits. So we've all been working really hard. COVID definitely affected us. We were closed for a while, and then we were partially open to some patients, you know, but it was a descriptive study and not a therapeutic study. And some patients were in the therapeutic study of testosterone. So we were able to complete at about 200 virtual visits over the COVID pandemic with some alterations to our protocols and basically, you know, missing a lot of the direct developmental assessments that we could do and the lab collections that we could do, but still getting updates on medical history and questionnaires and all of those things that we could collect electronically. And we still enrolled 50 new participants during that time. So we had a very busy COVID season with a lot of alterations to the protocol, but still I feel we're pretty productive, although there's going to be some gaps and holes in the data. And I think this is something all researchers are going to have to, you know, kind of figure out what to do with because it affected all of us. So looking at the results, these are just some preliminary results from various abstracts and things that we've put together. I want to share a little bit about developmental profiles. This is profiles from individuals who we saw at 6 months, 12 months, and 24 months of age, and the ends in each group here, 198 and 42 patients. The numbers go down, obviously, as the age groups go up because we have patients who are catching up and getting older from the cohort. I do want to show and share the race and ethnicity data. I feel like even though it's not perfect, we actually have done a really pretty good job in terms of recruiting a diverse sample with 70, you know, 70% Caucasian in the sample, and then, you know, a high proportion of Hispanic populations. These could definitely be better, but many of our populations sometimes are in the 90s when it comes to percent Caucasian. So this is I think you know, nice diverse sample. We did some t-tests along the way and some repeated measures of ANOVA that I will share with you over here. So now to share some results of the developmental assessment, this slide shows you the different domains that we measure on the Bailey: cognitive, receptive language, expressive language, fine motor skills, gross motor skills, and then the mean scores in the groups at 6 months in the blue, 12 months in the red, and 24 months in the gray. In the standardization sample in general population, we expect a mean score of 10 with a standard deviation of 3. And so what you can see here is that in our group, our infants had a mean scores that were right around where they should be for their age in terms of the cognitive domains. And, you know, standard deviations that pretty much ranged in what we would expect for the general population. When you looked at receptive language and expressive language, they were statistically lower than the standardization sample. And so many of the scores extended a little lower, obviously, than the average range. And so we saw higher rates of developmental delays and an overall lower mean score. However, it's really important to note that these are still, you know, well within the mean scores are well within the average. It was not as statistically different at 24 months. And I think that's interesting when you look at the longitudinal data, which I'll show you on the next slide as well. Expressive language was impaired and statistically different across all ages. Fine motor skills were actually all, this one was a little bit lower, but overall fine motor skills were also fairly consistent with the standardization sample. And then gross motor domain did show statistically significant decreases in the mean scores. When we looked at the longitudinal cohort, it was interesting in that the significant differences when you looked across time were mainly in terms of the receptive language, which decreased and then improved again. And this is what you see when you looked at the means across time and kind of in larger cohorts as well, where receptive language seemed to be a little bit lower at the beginning and then ended up back in the typical range, whereas the two domains that stayed lower were expressive language and gross motor skills. And you can see up here cognition and fine motor skills were stable and also closer to the mean. Okay, so then I wanted to share some of the interesting other findings that we have, and because this is a genetic audience, I thought I would share some of the discrepancies, because obviously we are obtaining all the results from the NIPT testing, and then we're looking at the postnatal diagnostic rates. And so, and I talked a little bit about the XXYY sample previously that we have. And so there is a cohort of individuals who had an NIPT result that was either XXY or XYY, but then postnatally came back to be XXYY. You know, I want to highlight these because I think it, number one, really highlights that it's really NIPS, right? And we need to do diagnostic testing, which I'm speaking to the choir when I say that. But I think not everybody really really recognizes the importance of diagnostic follow-up with an NIPS result. And then, you know, honestly, the stress of a prenatal diagnosis by itself is, you know, pretty significant for families, even with the trisomy. But the counseling for a trisomy is somewhat different than the counseling for a tetrasomy, where there is a lot more involvement from a medical and neurodevelopmental perspective. And so for some of these families, they felt like, okay, well, we can, you know, handle the prenatal diagnosis of a trisomy. And then when it was actually confirmed postnatally, kind of had to go through a whole process again to understand that there may be some differences in more severe involvement than what they first anticipated. We also do some psychosocial, measures. We have one of the questionnaires we measure is called the Parenting Stress Index. And we have lots of other questionnaires related to infant temperament and the parent experience and other things that we're collecting as well that I think will really add and contribute a lot of information about the experience of a prenatal diagnosis and help inform counseling as well. And this was a preliminary study that we put together about a year or so ago, where we looked at the parenting stress index scores of the parents, when the parents filled it out at 2 months, 6 months, and 12 months of age. And what was interesting to us, we would hypothesize that a T-score of 50, which would be average, that this population maybe had higher parenting stress, right? That they, had children who were at risk for delays and that they may have, had higher levels of stress. But actually, when we looked at their scores, they actually were within the typical range, and some of them even lower than we would expect compared to the general population sample. And so this was a little bit of a surprise to us. And, I think it needs a little bit more exploration, probably with some more qualitative type measures. Some of our hypotheses in terms of understanding these results would be that, there are now families who are in a study, so they maybe feel less stressed because there is, very close follow-up of their kids. Or maybe the stress really all happened prenatally, right? And then once they have this generally very healthy baby who's thriving and developing, their stress levels decrease. And so, I think this is important information to help us in terms of the parent experience. When we looked at things over time, we actually saw that there were some significant decreases in child stress. This is the parent reporting on how much stress they have related to different aspects of caring for their child, and then other different life stressors that may be not related to parenting and the child itself. And over time, we actually saw that these scores decreased. And so, again, maybe over time, as their infant is growing and, generally doing well, there is less stress related to parenting. So those are just a few of the preliminary results that we have. We're waiting on a big cohort of hundreds and hundreds of testosterone and hormone levels in all of the individuals that is going to give us information that I think is unprecedented in terms of the sample size of what we'll be able to say about the time course of early hormone profiles in all three of the trisomy conditions. We have a lot more data to analyze related to medical problems and features and, many, many other questionnaires and things that we've been collecting. So this is just a sample, and there will be many papers to come that we're working on actively. But what I thought we'd do now is maybe switch a little bit to talking just about the idea of newborn screening in this group. Because this is, something that comes up all the time with families, and this being NBSTRN, obviously, I thought we would talk about it. And so, the big question is, does everyone with SCA obviously need to be identified, and should they be identified in the newborn period? And, I would definitely say that current research does not include results that would support newborn screening based on the ACE-DNC decision matrix, right? Which helps the advisory committee really make recommendations about what's included on the newborn screening panels. First of all, we need a validated lab test. And then there's really more importantly, I think, and the bigger question is the need to establish if there would be a clear benefit to a newborn diagnosis. So just talking about the lab test briefly, there isn't one that's necessarily been validated for all of the SCA variations for use in a newborn screening type of setting. But, I think this would be something that would not be that challenging to do. There was a study that was done and a test that was developed by Steve Warren and colleagues and led by Brad Coffey at Emory, where basically they did newborn screening using their Fragile X test. And then, you know, incidentally identified many individuals who had an extra X chromosome because they were obviously looking for changes in the X chromosome related to the methylation of the FMR1 gene. And what was surprising and interesting, this study screened the Atlanta blood spots for, I think, 2 years and looked at all of them and found a total of 7 positive cases of Fragile X syndrome, but 57 cases of Klinefelter syndrome, which was not what they were originally developing the test for, but which I think is a really important finding when you start to think about many of these genetic screenings that will then incidentally pick up all these other individuals. And so, you know, what do you do with this cohort here in terms of these findings? When we talk about newborn screening in terms of early diagnosis, I think there are definitely topics related to hormonal treatments that make the idea of newborn screening definitely worth the conversation. We talked about the hormonal you know, the hormonal surge of testosterone in infancy or the mini puberty of infancy. And there are preliminary studies that suggest there may be benefits to developmental outcomes related to receiving testosterone supplementation in infancy. But these really are not done and have not been done in a rigorously controlled way, prospectively. And so I think we need some more rigorous studies to really show and look at whether or not those are, that there really is any benefit to early hormonal treatments and what those benefits may be. There is definitely a little bit of preliminary support that that testosterone treatment in early infancy can improve body composition and decrease adiposity, increasing muscle mass. And so these are things that, you know, the importance of this moving forward in terms of motor development, it would be something that you could argue if there are indeed health benefits to replacing testosterone in the newborn period and neurodevelopmental benefits, that it would be an important diagnosis to have in the newborn period, so it could be done during that time. I think we could all argue that it's important to know about the presence of the extra X chromosome when it comes time for puberty, when there is almost universal testosterone deficiency in males with an extra X chromosome. And so many of these patients do need testosterone for things like pubertal progression, to prevent gynecomastia, which has pretty significant self-esteem consequences when it does present. It's important for physical health in terms of bone health, physical endurance, sexual function. Obviously, hormones do play a role in mental health as well, and quality of life. And then fertility preservation is something else. There's a lot of research going on related to the timing of testosterone treatment, related to efforts to preserve fertility or at least retrieve sperm from the testes, and a lot of questions about whether or not this should be done earlier. These are all really active questions right now. I don't think anyone has a clear answer, but I would say that those individuals who are not diagnosed with XXY until much later in puberty or even in adulthood and have had some of these consequences of decreased testosterone over the course of adolescence definitely would have benefited from knowing at the beginning of puberty in terms of all of these different aspects. You know, we talk about early diagnosis from the perspective of early development. You know, speech and language skills and motor skills, both are important early on. And we talk about the importance of early interventions, but really the importance of early interventions is to set the stage for what those skills do later, right, in terms of outcomes. And so, We know that early speech and language skills lead to and then set the stage for reading, academics, communication, social skills, self-expression, behavior, self-esteem, and then motor skills, writing, art, any kinds of manual tasks and work, self-care, independence, physical activities, sports and kind of cardiac and muscular health. So identifying the delays and being able to intervene early in these domains where we know there are already challenges is important, right? And so the idea of newborn screening for just being able to screen for and identify developmental delays in those kids who are at risk is one argument that a lot of people have in terms of being able to improve outcomes by knowing from an early age. Obviously, it would then later on in school age lead to improvements in academic outcomes, really help address timely intervention for the risk conditions that come with this, and minimize, the diagnostic odyssey that a lot of families go through when there are challenges across multiple domains that they've been trying to understand in their children and teens for many, many years. I say this part with the perspective and the hat of a clinician who cares for and sees a lot of kids diagnosed later on and who have gone through years of evaluations and various therapies and a lot of grief and challenges from a mental health and emotional perspective in terms of trying to understand what was happening with their children, and then a later diagnosis when someone finally did genetic testing, really led to some better understanding and treatments to improve those outcomes. And then obviously, thinking about the effect long-term on educational, occupational, mental health, and quality of life outcomes, if you're aware of and can intervene early and throughout the lifespan for the challenges that may arise. We also talk a lot, and people will say, well, the sex chromosome trisomies, I don't know that I'd put that high on the list for newborn screening because there is such phenotypic variability. Do they all really need to be identified, or can't you just identify those who have delays and then treat those who have delays, and are identified by the routine mechanisms by which we currently identify kids with developmental delays and get them into early intervention? And I would say that I fully recognize the phenotypic variability, and there are many individuals who go through with really minimal involvement. And so is there a benefit to knowing about their diagnosis early? Well, from the neurodevelopmental or mental health perspective, maybe not, definitely from the testosterone perspective later, but I see and understand that argument when you compare it to some of the conditions that are clearly needed in terms of newborn screening and the consequences of lack of misdiagnosis in those cases. The challenges, some ways, are that we do have developmental and autism screening recommended by AAP as part of well child care visits, and hopefully in good practice that's being done. And we do have pretty good recommendations in terms of genetic testing for clinical features. If there is global developmental delay, ASD or ID, that should pick up these kids, right? If they're presenting with global delays or autism, there should be genetic testing. The challenge is that there's a couple things here. One is that, as you guys know, this is not always consistently done, and it's especially not consistently done if there aren't other medical problems or facial features that are concerning. And it's not always consistently done if there are milder presentations. There's a lot of, well, our doctor just told us to wait and see. And then we did a study actually where there was about a 2 to 5 year delay between the time the parents raised concerns and before someone would order genetic testing. And so that's a long time of challenges that could, have some interventions. And then honestly, a lot of the current genetic testing guidelines, even though they're there, they don't really cover most of the phenotypic features that cause pretty significant morbidity in terms of learning disabilities and ADHD and emotional features like anxiety or depression. Right now, those are not things that that people would do genetic testing for. And so even our genetic testing guidelines clinically miss it. So how are we going to find all of these patients to be able to understand them, and do they all need to be found? I think there's a lot of discussion that people can have about this. There's also a lot of ethical concerns about parental attachment, about different approaches to parenting, parental stress, if indeed you do know about the diagnosis. And I think there's both sides of the coin here, where some people will say, oh my gosh, we're so glad to know early, then we can follow and watch. And there are other parents in the study who's, generally in the kids who have been doing well, whose parents are saying, I wish I didn't know. And there's, I'm glad to be in the study and I'm glad to contribute, but, in some ways, compared to my other kids, there really aren't any differences. And I'm not sure, right now I need to know. Now that may change over time and may not, but I think there's always, the idea that sometimes parents don't want to look at their child and then, depending on personality of the parent, be worrying about some of the risks that are carried on throughout life. Okay, so what are we doing next? Well, we are starting in July 1st, our 5th year of our funding cycle, and looking forward to an active year of seeing patients and trying to catch up from COVID in terms of figuring out priorities of who to see. We've got hundreds of visits to try and figure out. So we have to make some priorities there, which we are going to prioritize our 36-month visits and then, fill in our other priority groups along the way. Our new proposal is definitely going to start for a renewal. We want to continue to follow this cohort and through the early school age years for some of the things that will show up later: reading, academics, language, attention challenges, and ADHD types of symptoms you can see later on. And then social development as well. All of these obviously become more complex and nuanced as kids get older. And so we really hope that we can follow them. We are going to continue data collection in our younger groups again, because I think some of our analyses are not going to be powered in a strong enough way if we don't have large cohorts. And then I think we have enough information in terms of trying to think about an intervention and pilot an intervention for speech and language development specifically, and then continue to explore some of our analyses from our bio. So first, I just want to thank NBSTRN and NICHD for the support and the funding. We have a really big group of our team in Colorado, and then our collaborators at Nemours and across different locations across the world. And that's it. So I'm happy to answer any questions.